All right, so we're going to talk about HIV and oral health. These are the objectives for this lesson. So, human immunodeficiency virus, or HIV, was first reported by the CDC in June and July of 1981 as an opportunistic illness. It is the virus that causes acquired immunodeficiency syndrome, or AIDS. It is a gradual impairment of the host's immune system. So it doesn't happen like within a couple days or 10 days kind of onset, like some viruses that you might think of, like if you get sick with a, whatever type of virus, but it's kind of a gradual impairment. And now it's really quite treatable actually at our stage now that with the medical advances. And so it's really almost thought of more as a chronic medical condition. The biggest issue is that there are still quite a few people around the world really who may not know that they are test seropositive or know that they have the virus, and so it's wanting everybody to bring awareness to understand if they have a high-risk lifestyle where they could be at higher risk of acquiring HIV, and then to be willing to be tested. The CDC actually recommends that everybody between the ages of like 13 and 64 be tested for HIV at least one time in their life. And they do consider it still a pandemic, which is interesting when I was reading through the chapter, just since this is an updated version from the last edition. So it should be noted that oral mucosal candidiasis was observed and documented in the very first cases of HIV. So that's an oral condition. So this is very much something that hygienists need to just be aware of. Some of the oral manifestations that are common for HIV. These oral manifestations you'll see as we go on are common for other things. It's not just HIV, so it's not like you see it and you go, oh my gosh, do they have AIDS? What should I ask them? How should I handle this? It's not necessarily that, but you do need to know these conditions, and so that you do know what proper questions to ask on the medical and dental history. So here's a little schematic from the text, and the typing is really quite small. You might be able to zoom in on the other, there's the regular PowerPoint so you can read it. But this I just thought was really kind of a nice image because it shows the life cycle of HIV and how it attaches to the CD4 cell, T lymphocyte cell, and how it sort of attaches there, and then how it kind of wiggles its way into the cytoplasm or into the through the cell membrane, and then how it deposits its RNA, and then it has this ability to do the reverse transcriptase. So it goes from RNA to DNA. So it's like usually we have DNA and it goes to RNA, but it does the reverse inside, not inside the nucleus yet, but just inside the cell, this white blood cell, this CD4 cell. So now that it's an HIV DNA, it has the ability to get into the nucleus of the CD4. And once it has the ability to get into the nucleus, then it can change the human cell, the CD4 cell. It can change the DNA. And then it comes out again, out of the nucleus, and it has these long chains, long protein chains, and then it can start to use these as building blocks to just go through the whole the whole human system and start to integrate this virus into the host, and then just slowly having a greater impairment on the host's immune system. So it's this very multi-stepped process. It's quite complicated, really, but it's like amazing when you break it down to these little steps to see how it actually wiggles its way into our system, kind of takes over cells, and then keeps replicating itself after that. So HIV immunosuppression is the major complication, or the kind of the impetus that gets so many other things going. It's the decreased ability of the body to mount a natural immune defense against disease-causing agents. So that's why so many things can go wrong. When the HIV patients that were testing positive in the early stages of this virus, they got so sick because so many different things could attack and kill them because they just had no immune defense. Opportunistic infections, of course, illnesses associated with severe immune suppression. So that's why, Candidiasis was one of the first oral manifestations to be noted among patients with AIDS or HIV, is because we know Candidiasis as an opportunistic infection. Kaposi sarcoma is a rare cancer of the blood vessels, and that can also be seen in individuals who are HIV positive, and we'll see some images of that. By some estimates, more than 90% of HIV-infected patients will have at least one HIV-related oral manifestation in the course of their disease. So it is incredibly common to see something orally related with a patient who's HIV positive. So how does HIV hijack the immune system? Well, we kind of went through this earlier. I probably should have put that schematic after this slide. I probably kind of was out of order, but HIV virion attaches to the white blood cell CD4 T lymphocytes. The CD4 T lymphocytes are not cytotoxic. They can't kill virus particles, so they really don't have it attaches itself to like the perfect thing. It's like a white blood cell, but it can't kill the virus. It can't really defend itself. The virion releases its RNA and uses the reverse transcriptase to convert viral RNA to DNA, HIV retrovirus. And then once DNA is established, it integrates into the host cell genome. Now HIV can just circulate and infect other cells throughout the human body. The virus suppresses the host's immune system, and there's no natural defense once it does this. So HIV is transmitted through bodily fluids, namely semen, vaginal secretions, breast milk, and then infected blood or platelets. And acute HIV, which is 6 to 56 days after exposure. So you can see it can take, close to 2 months in some cases for the virus to show itself. But in acute HIV, fever, lymphadenopathy, headache, rash, pharyngitis, malaise, aching muscles, and arthralgia, aching joints is all very common. So it has been reported that most persons who are undergoing seroconversion, or the acquisition of the antibodies in the blood serum, are often ill enough to seek medical attention. So very often somebody who is just been exposed and they are starting to develop HIV, they usually feel bad enough that they take themselves to the doctor. Acute HIV infection is also characterized by primary viremia, or the initial spike in the viral levels in the bloodstream. So HIV and AIDS drug therapy, it's had kind of a rocky road, but they've gotten to a pretty good place now. In the 1980s, it was monotherapy of enzyme responsible for the reverse transcriptase. It led to a lot of mutation and drug resistance. So the virus is smart and figured out how to resist the monotherapy that they had initially. So then there was more research and testing, and then there was kind of like an HIV cocktail. There was at least 3 drugs, if not more, and then finally they get to a place where they have something called highly active antiretroviral therapy, or HART, and that's the standard of care. But now it's and that was, they had several different drugs, and you had to take them at different times, and some with food, some without food, and it was like patients, what do you call it when, oh my gosh, the word is not in my head, but if you're going to cooperate, patient, anyways, it was difficult for the patients to actually cooperate with it and stay on track, because it was kind of complicated to take the system. But now the HART therapy started to become the standard of care, and now it's referred to simply as anti-retroviral treatment, as ART, so they've just kind of simplified it. And a lot of times it's just a 1-a-day, 1 pill, but it has several medications in the 1 pill. So it's much easier to take it now. So today's HIV regimens are all better tolerated and easier to manage compared to earlier regimens. They are recommended for everyone diagnosed with HIV to preserve the immune system and improve health outcomes. Treating HIV as soon as it is diagnosed, rather than waiting for complications associated with immune dysfunction or a decrease in CD4 counts below the threshold, results in better outcomes. So during acute HIV, so during the initial phases, some oral manifestations that can be present are erythematous round patches on the hard and soft palate, angular cheilitis, exudative tonsillitis, hairy leukoplakia on the lateral borders of the tongue, and oral ulcers pretty much anywhere in the mouth or on the lips. So HIV and aging, there's a lot of individuals now who had AIDS. Well, I don't know if a lot, but there's individuals now who had AIDS in the early 90s, maybe late 80s, early 90s. And now they're, possibly even into their 50s and 60s and so, or older even, who knows. And so HIV is considered a chronic disease, but then you also have all these age-related comorbidities that just go along with aging. So, there's a lot of, it can make for quite a complicated medical history. So non-AIDS, there's these age-related comorbidities could be non-AIDS defining malignancies. They could have cancer for, just non-AIDS related reasons, cardiovascular disease, diabetes, bone density issues, and bone loss. So these comorbidities require consultation with the physicians of record as to any contraindications for dental care. So if we know that we have a patient who is HIV positive or does have AIDS, we also want to carefully look at their medications and other comorbidities that they have, and kind of talk to them about their regimen, their frequency that they see the doctor, their overall health, stability, how stable are these conditions, and are they having any oral manifestations that they notice or that we notice once we get in there and look inside their mouth. So the HIV Care Continuum really is a continuum. It's not, something that they're ever going to be able to walk away from or be like, I'm done taking this medication. It's something that's just with them for life. So timely linkage to care and retention in care significantly affects health outcomes and are linked with high rates of viral suppression. So the first stage is testing and diagnosis. However, 14 to 18% are unaware of their infection. So that is, a fairly good chunk of people who are unaware that they're infected, and they can infect other people if they don't know that they're seropositive. So knowing one's status in the path to linkage and retention in care, the CDC recommends everyone should be tested at least once in their lifetime. So the process of care, obviously, it's so important that we're professional, that we do a thorough, investigation of their health history to establish whether or not somebody could possibly be HIV positive. So if we have any little little red flags that go up and say, this seems unusual to me. It's important that we handle it in a very professional manner and in a manner that we feel comfortable talking, and we also are helping our patient to feel comfortable as well. So building trust with the patient is so important. Building rapport, building trust, absolutely having no thoughts, or helping them to not think that we would ever break confidentiality, how important that is. And then the importance of gathering all sensitive information. So explaining to the patient the importance of knowing all of the sensitive information so that we can help them with better health outcomes. So if we're unaware of something, then we're not going to be able to provide them with the best oral health care. So it can be a very sensitive topic, and it can be challenging in the beginning as a new practitioner to kind of know how to traverse that territory. But ensuring confidentiality, being professional, showing empathy, and building trust are some of the best tools really that we have for that. And then being familiar with some of the drugs that are out there. When you see on their health history, there's the nucleoside reverse transcriptase inhibitors, NRTIs. There's non-nucleoside reverse transcriptase inhibitors, and NRTIs. There's protease inhibitors, PIs, and then there's integrase inhibitors. And a lot of times somebody who maybe has been HIV positive for a while, or has had AIDS for a while, they may have been on just a once-a-day multi-drug that's in just one pill once a day. And they might have been doing it for years, and they're just very stable and seem very healthy. So, I mean, it can look very different for different patients, just like with any chronic disease. So we have to be sensitive to their challenges. We have to be very sensitive to the social stigma, reluctant or fearful to seek dental hygiene care. So some individuals may feel like they wouldn't want to be seen, that healthcare providers would be afraid of them. And they don't want to feel like an outcast, so they just won't put themselves in to a place where they could feel, uncomfortable themselves. And so if they might figure, oh, nothing in my mouth hurts, I'm not going to go seek out regular care. They might not want to see me anyways. And so reassuring people that there is no greater danger to us, because we treat everybody like they have an infectious disease, because that's how we stay the safest, is with our universal precautions, our infection control, our standard precautions, whatever we call it nowadays. And so reassuring people of that, and so that they feel comfortable and safe and welcome. And be open to shaking hands when you first meet somebody. Once you find out that I say that now, and just as I'm saying that out loud, I'm like, we don't shake anybody's hand anymore because of COVID. So, but basically, the take-home message is treat them like any other person you treat them. At this moment, you'd be standing 6 feet away wearing a mask. But, in the future, if this all, goes away, we just treat them as if they are just any other person. You cannot get AIDS by touching somebody's skin, or giving them a hug. Not that we hug our patients that often, but you can't get HIV that way. So we need to use our logic and not be afraid to treat somebody and with the same mannerisms that we would just any patient. So it restores a sense of safety for both. It's polite. It diffuses unwarranted fears and alienation. So that's why that goes specifically with shaking hands. But nowadays we don't shake anybody's hands, but maybe that'll go away one day, and then we can go back to it. Okay, so the dental hygienist care plan for a PLWH is a person living with HIV, and it should be the same as for any HIV negative patient. So there really is, in general, if somebody comes into your practice and they are HIV positive, there really is nothing that you go, oh my gosh, this is a whole new protocol. If they are in pretty much decent health and they're stable, then you just treat them like any other patient. You want to educate the patient on the importance of good oral hygiene and how that can prevent or, I think there's a typo there. How can prevent oral lesions lessen, I think that's supposed to be lessen severity of many oral manifestations. So the healthier they keep their mouth, of course, that's just going to be better for their overall health. Gives patients a sense of control over their disease, letting them know that, the choices they make a huge difference. Encourage patients to take responsibility over their oral health and understand oral and systemic health-related issues. So when we educate them about how much the oral health is linked to systemic, and that matters so much with patients who are HIV positive. So it's an important conversation for us to have with them. So planning dental hygiene care is really often very much like just anybody else. We educate, we execute our therapy, we reinforce biofilm control, we give our post-treatment instructions, we evaluate and assess, continue the cycle of evaluation, assessments, and future treatments. We integrate dental hygiene treatment with consultation from a physician if something is out of the ordinary, or if there is something happening that is not stabilized and not controlled. More severe cases, we're going to collaborate with the dentist and the physician. Counseling and education is imperative for both for the patient's health, for their oral health, and for any conditions related to the HIV or AIDS status that they have systemically. We want to take advantage of HIV positive patients' desire to prevent disease and stay healthy. They oftentimes are so acutely aware of their need to prevent disease that if they are in your dental chair, they are going to be very open to your recommendations. If they haven't made it into a dentist's office, that's just might be some other barrier. But once they're in your chair, they are going to oftentimes be very, very open to good oral hygiene practices. Implementation considerations. So, of course, infection control, we do it the same for everybody. It keeps us safe, and we know this. SRP, some people used to be afraid of ultrasonic, using an ultrasonic for SRP or, peri-maintenance or prophies, but it's totally fine. Once again, at the time of this recording, we're going through the COVID pandemic, and so obviously we're not using ultrasonics the same as we were, but if things go back, to normal, you are completely fine to use an ultrasonic on an individual that's HIV positive or has AIDS. Aerosols is not a mode of infection with HIV. Patients with HIV present with the same needs as non-HIV patients when it comes to their oral health. So there's, really nothing massively different right out the gate. So the Surgeon General, Regina Benjamin, said, while good oral health is important to the well-being of all population groups, it is especially critical for people living with HIV and AIDS. Inadequate oral health care can undermine HIV treatment and diminish quality of life, yet many individuals living with HIV are not receiving the necessary oral health care that would optimize their treatment. I just thought that was in the text, and I just thought, I got to put that in here because it's not just true for HIV individuals, HIV positive individuals. It's true for other people with chronic conditions, is that a healthy mouth really is a major key player in some other chronic conditions, and HIV being one of them. And it just shows how vitally important we are to people, and how important our message is and what we do is. So here's some images of some oral manifestations, individuals that are HIV positive or have AIDS, and we'll talk a little bit about these here. So oral candidiasis, of course, this can be seen in other situations, not just somebody who has AIDS, anybody really who tends to be immunocompromised. can be at higher risk for candidiasis, but there's a couple different types. There's the kind that you see in this picture here that's the pseudomembranous candidiasis. It's that kind of yellowish, whitish plaque, curd-like, cheese-like buildup. And then when you wipe it off underneath, it's very red underneath. And that oftentimes is on the hard and soft palate, buccal mucosa, all over the tongue. It can be different places. Then there's the erythematous candidiasis, and that doesn't have the white buildup of the plaque. It is just kind of red, denuded. It burns a lot. It's usually can be on the tongue, desquamative, gingivitis, and it's easier to miss sometimes because it doesn't have that white, cheesy stuff all over the place. And then atrophic candidiasis, hyperplastic candidiasis, and then angular cheilitis is another yeast. So the treatment oftentimes are topical, like nystatin or clotrimazole, whatever. Okay. And then sometimes I forget I'm recording and I just try and pronounce it better. And then I'm like, oh crap, I'm just recording. Okay. So, and then a systemic antifungal is another common addition, especially if the individual is very, very sick or immunocompromised. If they're battling it quite hard, then they're going to have a systemic antifungal like I can't even say it. Now I'm all self-conscious. You can read it right there. Immunocompromised likely will need systemic antifungal, like we said. So let's see, what's the next one here? Fluconazole. There, I just said it. I had to say it before I changed the slide. Okay. Oral manifestations continued. Hairy leukoplakia, thick asymmetrical white lesion. You can see that on the side of the tongue there, lateral borders of the tongue. Epstein-Barr virus is the usually what it stems from. And then it's almost exclusively in HIV and AIDS patients. And the treatment, usually it responds quite well to their just regular heart or ART treatment. So oftentimes I think it might be seen in people before they start treatment. Oral Kaposi sarcoma can appear anywhere in the oral cavity. Causative factors, viral infection with human herpes virus 8, alterations in the immune system. So Kaposi sarcoma is one of the first signs that triggers the awareness of the virus. It was one of the first signs that triggered the awareness of the virus and the epidemic. So since the advent, though, of the ART therapy, it's seen less frequently, which is good. However, it's still seen in individuals out of care and those unaware of their serostatus. So people who have dropped out and stopped taking their medication, or if they don't know that they're HIV positive, you can still see the Kaposi sarcoma. So local and systemic chemotherapy is the treatment. If there's a tumor around an area that we're trying to scale in root plane, that's okay. We can clean around it as best we can. It might even help the tumor, and then encourage, of course, good oral hygiene. So here's an image up on the palette here of a Kaposi sarcoma. That it's the malignant, slow-growing endothelial cell neoplasm, and then here is some, because it can be anywhere on the body. So here's another example of it on the side of a foot, an ankle. Squamous cell carcinoma is the most common type of oral cancer. In general, 90% of all oral cancers are squamous cell, diagnosed by biopsy. And of course, if we see something, of course, we're going to refer them right to their physician. Idiopathic lesions, aphthous ulcers, they occur on non-keratinized tissue, and they're very painful. We've all had, most, at least the majority of us, I'm sure, have had aphthous ulcers, and we know how painful they can be. Lesions of the periodontium, so necrotizing ulcerative periodontitis or NUP, deep jaw pain, fetid odor, bleeding, loose teeth, associated with severe immune suppression. And it's not just seen in individuals with AIDS. I remember one time listening to a hygienist talk about her father who just out of nowhere started having this horrendous periodontitis. And the doctors, the dentist was sort of slow to react, and she was like, no, this is not normal. This is crazy not normal. And she kept telling her dad to go to see the doctor, and he finally went, and he had leukemia, and he died very quickly. It was a super aggressive type of leukemia. And so, you know, this NUP can show up in other incidences, but with very sick individuals with HIV AIDS, then that's when you would see it. Very painful, areas of dead bone, areas of exposed bone, sloughing tissue, referred to as necrotizing ulcerative stomatitis. Infected bone may need to be removed for healing. So yeah, it's really quite awful. So treatment, there may be periodontal surgery to remove the necrotized tissue, antibiotics, metronidazole, chlorhexidine 2 times a day, kind of have the patient do a irrigation with a blunt needle syringe. When tolerable, meticulous oral hygiene. Sometimes it takes a while for them to use mechanical things like proxy brushes and that because of the incredible pain. Definitive scaling and root planing, and careful monitoring once things seem to be getting under control. HIV and AIDS patients with NUP also might have Candida and herpes virus present. Subgingival yeast often seen much more often. Candida albicans may be causative factor in severity. So they could need, you know, on top of all the perio associated therapy, they may need like a systemic antifungal. May be unresponsive to traditional dental hygiene therapy. Complex Candida, herpes virus, xerostomia, altered lymphocyte action, poor nutrition. There's just so many. If they're very, very, very sick, and all of this is happening, it's a very complex, and they may, you know, you would want to, if you see someone in your chair that's this sick, you do all the things that you can, but you consult with a physician first, just to probably run it by them, make sure, tell them what you want to do, find out if everything is okay to try, and then move forward like that. So here's just some images. This slide talks a little bit about NUG, the necrotizing ulcerative gingivitis, and then NUP, and then linear gingival erythema. So just a couple different manifestations of periodontal lesions, and then some images to go along with it. So other things that can be present. I am just doing fabulous with this one today. Lymphadenopathy, human papillomavirus or oral warts, recurrent herpes simplex, variety of infections, neoplasms, and other oral lesions. So it's our job to assess, identify, inform, and then refer or consult with physicians, and then also treat. So that's our, you know, we're not going to necessarily absolutely know everything that we're looking at, but if we take pictures, if we record, we do our best to assess all the things that we're finding in their mouth, then we can confer with the dentist and the physician, and just that's our job, to help make the patient's outcomes the best that they possibly could be. So what's the risk to us? What's the risk to healthcare workers? So precutaneous blood exposure, as of 2013, since they started recording confirmed seroconversions, I think they started in the 90s is when they started recording them. So from the 90s to 2013, there's been 58 confirmed seroconversions. So that's very, very, very small number for occupational exposure, and there has been none in the dental workforce. So the risk is 0.3% for healthcare workers. Dental hygiene students and practitioners must follow best practices to minimize exposure to risk, infection control, barrier protection, adequate sterilization, action plan for exposure incident, which is usually a short course of antiretroviral drugs. The other thing I wanted to mention, I don't have a slide, but there are patients out there you may see who are on a prophylactic drug to prevent contracting HIV. They may be in a high-risk category. So homosexual men or what was the other anybody who uses needles, intravenous drug users. They tend to be the populations that tend to contract HIV more frequently. So if somebody is has a lifestyle that might be considered more high risk, some have chosen to take a prophylactic medication, which pretty much prevents, it's almost like taking a constant, vaccine, sort of like a daily vaccine, basically, because there is no HIV vaccine, but you can take a medication that would make it so that your body could defend itself, and so that you wouldn't seroconvert if you happen to have sexual intercourse with somebody who's HIV positive. So it's possible that you could have somebody in your chair that is taking an AIDS or an HIV medication, but they're not HIV positive. So if that ever happens, then that's why, because they're basically taking it prophylactically to prevent it. So that was my last bit of information. All right. Thank you.